Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome to this week's podcast. Today we have Dr. Winston de Mello, founder of the college, and he'll be talking about TXA.
Good morning, everyone, and welcome to this podcast. And thank you for the introduction, Ibrick. Tranexamic acid, or TXA, and I'll use TXA as a shorthand, is a drug that is becoming in common use for those involved in the trauma world. TXA is a synthetic analog of the amino acid lysine. Lysine receptors are present on plasminogen. So if you block these lysine receptors, you reduce the breakdown of plasminogen to plasmin. So the net effect is that it prevents fibrin degradation and it preserves the framework of fibrin matrix. Now, as you know, when you bleed, you have the coagulation system, and then the clot is broken down in due course by the fibrinolytic process. So the first thing to note is that TXA is an anti-fibrinolytic agent. Now, one of the problems that will manifest itself is that if it prevents the breakdown of clots, would it also cause problems with clots causing vaso-occlusion? So when we talk about the side effects or the possible problems, then we have to bear in mind the physiological process and bear in mind how the drug works. So in summary, TXA is an anti-fibrinolytic agent, and I've described the mechanism that it reversibly binds the lysine receptor sites on plasminogen and therefore prevents breakdown of clots and therefore reduces the amount of bleeding in trauma.
So, Winston, everyone's talking about this drug. It's just popping up left and right. But is this new? How long has this drug been around?
Well, I was quite surprised when I actually looked back at the drug journey. It was first synthesized in 1962 by Shosuke and Okamoto, two Japanese scientists. And as a young doctor, I was using it for heavy periods. It was the drug for heavy periods. So it has been present since the 1960s, but it's become more prominent as a result of its role in major trauma. Now, what has it been used for in the past? Well, besides its obvious use in preventing excessive blood loss in major trauma, it's also been used in postpartum hemorrhage, in various surgical procedures, in dental extraction in patients with a coagulopathy like hemophilia, nosebleeds, heavy menstruation, which I mentioned earlier, and hereditary angioedema. So you can see that we've got quite an extensive use of the drug, but its use in trauma is relatively new, say in the last decade or so.
So everyone's talking about it. TCCC just up to I think 2 grams initial dose. Is there any side of it? Is there anything that can cause problems by having such a massive dose of TXA?
Well, let's look first of all at the side effects. First of all, they're rare. There was a worry about causing seizures, but I think the current evidence is that it is not a absolute contraindication, but it's a relative contraindication. It does cause problems with color vision, the propensity to blood clots, and obviously, if the patient's allergic to the drug, then it's a absolute contraindication. As it's treated by the kidneys, you would need a lower dose in chronic kidney disease. However, to answer your point about the changes in dosage, as the renal system is the one as its major point of excretion, in a single use, the dose doesn't really matter. However, the use in trauma, you mentioned 2 grams loading dose of TXA. Prior to this, it was 1 gram of TXA given over 10 minutes, and then 1 gram over the next 8 hours. This was the basis of the various crash trials, which we'll talk about in a second. The secret seems to be the quicker you use the TXA in major trauma, the better it is. And as the longer the delay, the less the efficacy. So what we're trying to say is to try and use it certainly within 3 hours, and if possible earlier. So it's a drug that should be sort of routinely thought of in major trauma where bleeding is a problem, and we will cover a little bit more about that when we consider the crash trials.
So now it's the drug of the month. It's the favorite candy to use for trauma. And how did that happen? So how did it come from a long history since the '60s of Menzies problems, and then suddenly used on an everyday trauma cases?
That's a good question. I mean, I need to go back a little in history. Do you remember the days when in trauma life support courses we put in a liter of normal saline stat?
I
Well,
do, like 2 liters
two
stat.
liters stat. And as a result of that, the blood pressure went off and the clots were blown off and the patient rebled. And you have to remember that the first clot is the best clot because once a clot is formed, you've used up coagulation factors. And the replacement of coagulation factors physiologically is not quick. So then we went into hypotensive resuscitation, where we didn't want to bring the pressure up to normal levels, but we wanted to leave it at a permissive hypotension level of the patient of the radial pulse, equivalent to about 90 millimeters of mercury systolic. And then we discovered, because of that, you had a timeline where if you didn't then repair fix the problem, you then had a lactic acidosis, and as you know, coagulopathy, acidosis, and hypothermia then forms the lethal triad of trauma. And then we began to look at survival with major bleeding and major trauma. So the CRASH 1 trial, which was nothing to do with TXA, it was actually to do with methylprednisolone. And it was looking at an RCT where methylprednisolone was given 2 grams over 1 hour and then 0.4 grams per hour for 48 hours. To cut a long story short, it did not make any clinically significant impact on head injuries before 8 hours or a GCS less than 14. So that CRASH 1 trial suggested that steroids like methylprednisolone should not be used routinely in head injuries. However, TXA was the subject of the CRASH 2 trial, and it was again an RCT which looked at TXA on death rates, vascular occlusive events, and the use of blood transfusions in trauma patients with significant hemorrhage. And the dose was 1 gram TXA over 10 minutes and 1 gram over 8 hours, given as quickly as possible. There was a small reduction in death rates, but really no impact on vascular occlusive events or the need for blood transfusion. And then the CRASH 3 trial, which was published in 2019, specifically looked at TXA on death, disability, vascular occlusive events on patients with TBI. And really, even though the trial had huge numbers, over 12,000 patients, the main clinical benefit was for mild to moderate TBI with a GCS of 9 to 15. And the conclusion was TXA was safe in TBI if given before 3 hours, and there was a reduction of head injury associated deaths. So that is how the TXA has been shown to help a certain subgroup of trauma patients and a subgroup of TBI patients. But I guess if you're on the ground and you've got a major trauma patient with either bleeding or with a TBI, the bottom line from a pragmatic point of view would be to use a TXA as quickly as possible, preferably within 3 hours. And I mentioned the trial dose of 1 gram TXA over 10 minutes and then 1 gram over 8 hours. You mentioned how the TCCC have now increased that dose to 2 grams. So it's an evolving subject. And I think as time goes on and the selection of which groups of patients is going to be the most of benefit is still to be decided. So from a practical point of view, major trauma with bleeding or significant TBI, use TXA as soon as possible.
That's been a profound benefit to traumatic cases, casualties in the military as well as civilian. And it's two fantastic uses that weren't used, hadn't been discovered. So what's coming up the pipeline, Winston? What's the latest uses of TXA?
Well, as you know, the world has gone through lots of changes as a result of the COVID pandemic. One of the results of that is the lack of blood, either because donors are not coming forward, B, the transfusion service is overwhelmed and cannot actually maintain a service to provide enough blood, certainly in the UK, for elective surgery. And this has become a political hot potato. Now, what is interesting, the professor of hematology at Liverpool made a criticism about the fact that although NICE guidelines, which in 2015 recommended TXA for prevention of or to minimize blood transfusion following surgery, was not being followed in at least 30% of patients of eligible surgery who did not get TXA. TXA was used for adults who are expected to have moderate blood loss during surgery. If you think about it, the estimates are that if hospitals complied with the NICE guidelines and the quality standard, this would prevent over 15,000 major surgical bleeds, saving 33,000 units of blood, and by consequence, save many millions of pounds for the NHS. So it's interesting how tranexamic acid, which was basically a gynecological or a dental use in clinical practice in its first few years, then found its role in major trauma and TBI, and now the shift into hospital practice, trying to minimize the blood loss in surgeries that would be assumed to have a moderate blood loss in surgery. So TXA is currently being used in very surgical procedures, and these vary quite considerably. They vary in things like cardiac surgery, obstetrics, pediatrics, neurosurgery, and orthopedics. However, we've just got to be careful about translating its use, say, for example, in trauma, and then into, say, orthopedics, which you would have thought would be a good choice. TXA in orthopedics does reduce the bleeding and transfusion in hip and knee joint replacements. And the good news, it does not appear to increase the thromboembolic risk in bone fracture surgery. And it is safe in patients with coronary artery disease. And what is really amazing, it's effective whether it's oral, topical, or IV administration. In obstetrics, it does not reduce the risk of PPH following vaginal delivery, and may not meaningfully decrease the risk of PPH for cesarean section. But interestingly, if used within 3 hours of a PPH, it reduces the mortality. So you can see that our medics who may be on their own, the use in PPH, whatever the reason, it may be one of those extended uses, provided you have got permission from your employers. Now, it's also been used in pediatrics, in high risk surgeries where there's a reduction in blood loss and also the amount of transfusion. And as I mentioned before, seizures are not considered as an absolute contraindication, and the thrombotic risk appears to be low. So I would say in the next few years, the use of TXA in surgery where there's a lot of blood loss will become more defined. Whether you use it prophylactically or as a response to blood loss, the jury is still out. So I think TXA, a very old drug, nearly 60 years ago when it was first released, is also, interestingly, available on the WHO list of essential medications. So you can imagine if it's on the WHO list, its use for lots of potential uses means that a medic working in the pre-hospital environment, whether home or abroad, knowledge about the use of TXA, I think, is very useful.
It sounds like a drug that does a bunch of different things, so it definitely should be on the top 10 drugs list for the remote medic.
Yes, I agree.
That's fascinating. Thanks, Winston, for that. And every time I hear about TXA, there's more and more things that I'm learning about it.
Yeah, it's certainly. I think it. This is the reason why I thought a quick overview about the drug would be useful to our listeners, and perhaps to think outside the box, outside trauma, and think about its potential uses in other bleeding situations, which you might be faced with, and without anything else to do other than to try TXA.
Thank you, Winston, for this. It's definitely been educational, and we look forward to hearing you next month.
Okay, you're welcome, and thank you for the opportunity.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is Corum, C-O-R-O-M, corum.org.